regarding the lap CBD exploration plus lap cholecystectomy, and you have already also shown the how to handle with the low setup with the use of ureteroscope in absence of cholecystoscope. Thank you very much. Our next speaker is Lieutenant Colonel Mohammad Nasiruddin. He is a young dynamic surgeon. He is serving in our armed forces. He is going to present the laparoscopic management of concomitant CBD, sorry, preoperative prediction of laparoscopic, difficult laparoscopic cholecystectomy. I would like to say, Nasir, to please end your session within 10-minute times. Thank you. Over to Nasir. Nasir, unmute yourself.
Thank you, sir. Sir, can you hear me, sir?
Yeah. Now you are audible.
Sir, Bismillahirrahmanirrahim. Respected chairperson, moderator, my teachers, senior and junior colleague, Assalamu alaikum. I, Lieutenant Colonel Mohammad Nasiruddin, welcome you all to my presentation. At first, my heartfelt gratitude to SCLSB and Professor Sardar Naim sir and Professor Somiron Mondol sir for this excellent virtual conference. And I am Lieutenant Colonel Nasir, working as a associate professor and classified surgical specialist and laparoscopic surgeon in CMH Dhaka. This is my hospital where I am working. This is the trusted and tested healthcare provider institute of Bangladesh. And my thanks to my two guide, Major General Mahabur Rahman sir, professor and colorectal surgeon and DGMS of Bangladesh Armed Forces, and Colonel Shakaut Hossain, professor and hepatobiliary surgeon, CMH Dhaka. So since advent in 1987, laparoscopic cholecystectomy has become the gold standard in the treatment of gallstone disease. The rate of conversion from laparoscopic cholecystectomy to open is now about 5 to 10%. It speaks about the improvement of minimal access surgery and skill of the surgeon. And so preoperative complexity estimation helps a surgeon whether to proceed a laparoscopic procedure by minimal invasive approach or perform an open procedure or referral to a experienced surgeon. The aim of the study was to identify the predictive factor for difficult cholecystectomy in Bangladeshi people. Since the first session of today's virtual conference, our pioneer surgeon again and again telling about the safety of patient and safety of the surgeon. So prediction of difficulties before a surgery is important for that. And by prediction, we can predict the risks of conversion or difficulty may be faced during the surgery. Patient can be informed preoperatively, and time and team of the surgery can be scheduled accordingly. And high risk patient, we can avoid from a junior surgeon, and we can place it as a academic training case for our trainee. So in our study, we say prospective observational study. We included 135 patients, those who all are underwent laparoscopic cholecystectomy in CMH Rangpur and CMH Dhaka and some private hospital. We divided the patient in two groups. One is easy and one is difficult group. In easy group, if the duration of surgery less than 60 minutes and there is no injury to the bile duct or there is no conversion. And in difficult group, if the duration of surgery more than 60 minutes and conversion to the open cholecystectomy or any injury to any organ. And our clinical and sonographical predictor of difficult laparoscopic cholecystectomy may be age, sex, BMI, a feature of acute inflammation, previous history of cholecystitis, gallbladder status, wall thickness, number of stone, pericholecystic collection, CVD diameter, and CVD stone. We excluded the emergency laparoscopic cholecystectomy procedure and the patient who have history of jaundice and cholangitis. And we also excluded the dilated common bile duct and patient with CBD stone as a junior surgeon like me. The operation was done under general anesthesia, and pneumoperitoneum was created by carbon dioxide, and we using 4 standard port. The timing were noted from the first port site incision to the last port site closure. The entire all case received their standard operation and follow-up. So in our series, there are 135 patients. Among them, most of the patients are group age from 31 to 40, and the mean age was 38 plus something. And among the patients, 70% were female and 30% were male. And preoperatively, we predict that about 80% patient will be easy, but after operation, we found 103, that is 76% surgery was easy to us, and 32 patient, that is 23% was difficult perioperatively. And finally, we assess the predictor for difficult laparoscopic cholecystectomy. We included the age, sex, BMI, history of cholecystitis with previous abdominal surgery, gallbladder wall thickness and pericholecystic collection, gallbladder status, number of stone, and liver parenchymal disease. And we put the data, and we did the statistical analysis by SPSS 23. The univariate, bivariate, and multivariate analysis showed that BMI, history of cholecystitis, history of previous surgery, increased gallbladder wall thickness, pericholecystic collection, contracted gallbladder, and parenchymal disease like some fatty liver and cirrhosis of the liver are statistically significant for difficult laparoscopic cholecystectomy. In our series, we don't find any significance for age and sex. So difficulty faced during our surgery, our total difficult case was 32. So we faced some difficulties in peritoneal cavity access, and some difficulty faced during the dissection of the callos and dissection of the gallbladder. And in some case, we face difficulties due to abnormal bleeding. And in some cases, we face the difficulty during the extraction of the gallbladder. And we converted 8 laparoscopic cholecystectomy to open procedure. So if we see the literature and some discussion about these topics, this is the original article by Sudhir Kumar Mohante and Ramakanto Mohante, published in 2017. Preoperative prediction of difficult laparoscopic cholecystectomy use clinical and ultrasonography parameter. Mean patient age was 34. And their analysis shows that age, sex, and duration of symptoms are not statistically significant, but BMI, fever, number of stone, number of attack, previous history of cholecystitis, obesity, presence of tenderness in acute case. In our series, there is no acute case. Gallbladder wall thickness, raised TLC count. We don't consider the total leukocyte count in our series, and was significant for prediction of difficult laparoscopic cholecystectomy. And this is a review article by Abdul Jahra Hussain and difficult laparoscopic cholecystectomy, current evidence and strategies of management, published in 2011 in surgical laparoscopy, endoscopy, and percutaneous technique. There was 91 studies, included 324,553 patients. And they categorize 5 major difficulties during laparoscopic surgery. And their incidence of iatrogenic injury was 0 to 0.06% of this series. And after the risk factor for difficult or the male sex in our series, we don't find, as our series is, I must tell, it is very small. And increase the age, acute and thick wall chronic cholecystitis, wide and short cystic duct, and cholecystodigestive fistula, also a difficult for laparoscopic cholecystectomy, and previous upper abdominal surgery, and obesity, liver cirrhosis, and anatomic variation, cholangiocarcinoma, and surgeon caseload also significant for their series. About the limitation of our presentation, I must tell that as a young surgeon, this is a very small series of study, and our inclusion prediction value of also not up to so much. So in conclusion, I tell preoperative prediction for difficult laparoscopic cholecystectomy is possible, and it can help the surgeon and for the patient. And junior surgeon like me, it is important to predict the complexity or difficulty might face during the surgery. It helps the patient, and as well as it also helps me. So সবাইকে বিজয় দিবসের শুভেচ্ছা এবং মুজিব বর্ষের শুভেচ্ছা।
Thank you, Lieutenant Colonel Nasiruddin. Thank for your excellent presentation and your study. I would like to ask Dr. Shaikh Aziz Chaudhary to present his paper, Baseball Diamond Concept in contrast to the conventional laparoscopic cholecystectomy. As you all know, that Shaikh Aziz Chaudhary is a very dynamic, very smart, enthusiastic surgeon. He is working in the Sylhet. He has already